Okay, good. Well, good morning, everybody. A wave from the other sites. Can you hear me on the other sites? Yeah, sounds good. Oh, Ellen is getting up.
Yes, we can hear you just fine, Richard. Thank you.
Yeah. All right. So we'll get started. As you know, we never obtain success in departmental attendance until 15 minutes late, when Dr. Bano starts talking. Oh, sorry. Oh, hi, Dr. Bano. I took the liberty of sending out the announcement we're going to do this to the research people and to the foundation. So Susan, whom most of you know is the director for research for Fraser Health, who approves all of these projects. Every single one is approved. And Jeff and his colleague from the foundation, because we're hoping they will become involved. We're planning on them becoming involved with helping fund some projects like this, and it's pretty exciting stuff. What we have is the three projects that, three of the projects that I was involved in. Another recently finished one, which it just occurred to me afterwards, is one that Dr. Brower was involved with, a tax postoperative bleeding and cardiac surgery, but that's really a separate type of study, so we won't discuss that. We have three projects that are now completed in terms of the data gathering and patient enrollment and all that sort of stuff, which were done with the assistance of the pediatric anesthesia research team. And it all started because they wanted some big people for their research, as you know, and they were running a little low on big people at the Children's Hospital, so we were able to help out. A friend of mine, Arthur Lamb, who was a very well-published neuroanesthetist, always had half of his studies unpublished, and that's because most of the work is involved in not doing the actual study, collecting the data, but in writing it up and presenting it for publication. And Arthur was terrible at that. So we have completed all the data collection on this. We've published, presented abstracts in that, but we've now got, what did Mark say, 6 months or a year of writing to do before they'll actually come out. But all of these will generate publishable papers. We're just going to, I want to introduce all of the people that have been involved from the children's/RCH research group. They're all named there. The group of people that have been kind enough to come out today are research associates and highly qualified, woefully underpaid engineers, and they will help. The research associates are highly qualified and also woefully underpaid, I want to point out, but and they each will introduce themselves and talk about the three studies which I listed on the thing. So I think Nick West, who is the elder.
Okay, thank you very much, and thank you for having us here. Thank you, Richard. So this is going to be, yes, a very whistle-stop tour of three studies that we've done. As Richard alluded to, there's much we still don't understand in the data that we've collected. So, this presentation really is by way of, acknowledging your assistance in helping us get to this point, and also, hopefully to, continue and the dialogue that helps us really to get to a proper understanding of what we got. Your questions, comments, and feedback are going to aid us in really what we do. So let me just quickly remind you of the studies and how long we've been here. So it was a little over 3 years ago we started our closed loop study, which we call iControl RP, phase 1 in February 2013. And that's really been sort of like our long-standing project here in the operating rooms at RCH. A related project, which we actually mostly conducted at Eagle Ridge Hospital, was looking at one component of that, which I'll talk about in a little while, NeuroSense. And then while we were here, we began with Richard the preoperative warming study, PALS, and that ran a little over a year. And as Richard also mentioned, the TAC study, the transfusion algorithm cardiac study, which we did with Dr. Bra, who I saw coming in somewhere, there he is, which was really a collaboration across Canada, initiated by the University Health Network in Toronto. But that's outside the scope of this study, so we won't be presenting any information from that study here. So just to really move on and just give a brief reminder to those of you who are involved about what the NeuroSense study was all about. it was really looking to gather some validation data for this NeuroSense monitor. So this NeuroSense monitor is very important to us because it forms the sort of the measurement device that we use in our closed loop system, which we'll talk about in a little bit more detail later. It is a Health Canada approved depth of hypnosis monitor used in operating rooms. It's commercially available in Canada. The purpose of the study was really to gather additional validation data for submission to the FDA. As I say, mostly we did this at Eagle Ridge Hospital, and it was mostly Aaron and Ariana and Sonia and occasionally myself that were there with you guys collecting all this data. So one piece that you actually couldn't see because you were blinded to this monitor was the NeuroSense monitor itself. So we didn't have it stood on a pole in the operating room. We had it actually hidden, lying on a grey box behind the patient monitor with a yellow piece of card over this display. So it is a bilateral EEG monitor for measuring depth of hypnosis, or getting a measure of depth of hypnosis, which it displays for the two separate hemispheres continuously in the orange and yellow numbers there. And the number it displays is what we call the WAV CNS, or the NeuroSense WAV CNS index. We also call the WAVE index, or the WAVE. It stands for wavelet anesthetic value of central nervous system. And like the BIS, it essentially runs from 100 fully awake down to a 0 of sort of fully suppressed EEG. Oh. Okay, it seems, yes, okay. All right, so our study hypothesis. Okay, so what we were really looking to do with this study was to evaluate the depth, that wave index, the number that we get from the NeuroSense, and compare it to recognized clinical observation signs of the patient, and also to compare it with drug dosing during the administration of the anesthetic. So a little bit more detail about the study, what we did in the study. So there's going to be a lot of information on this next slide, but we were basically looking at 3 separate phases: the induction phase of anesthesia, the maintenance phase, and the emergence phase. During the induction phase, which was essentially a propofol induction, we looked at signs for loss of consciousness. So all of which may be widely disputed as accurate signs of loss of consciousness, but we look for loss of count, counting backwards from 100. What time did the patient stop doing that? Dropping a ball, a big heavy blue ball, which you may remember we had some fun chasing across the floor of the operating room, and loss of eyelash reflex, Richard's particular favorite mechanism for checking loss of consciousness. And also looked at response to intubation and aerosol lidocaine spray. During the maintenance phase, we actually asked you to randomly change the anesthetic dosing using desflurane, starting at MAC 1.2. We would ask you to randomly go up or down according to a randomization schedule, which you were allowed to accept or reject. And we changed that every 7.5 minutes, with a third chance of going up, a third chance of going down, or a third chance of staying where we were. And then again, during the emergence phase, we looked at signs of return of consciousness. And we did that, as I say, mostly at Eagle Ridge, 76 participants recruited. We have all the data. We have actually only just really, this study was sponsored by NeuroSense, NeuroWave, the company that manufactured the NeuroSense. They have given us now license to go and analyze that data. So I'm just going to introduce Matthias Gerges to come. He's one of our engineers, and he's going to explain a little bit our first look at this data, really.
Yeah, so good morning. I'm an engineer in the group, and I'm also going to be an assistant professor in anesthesiology, pharmacology, and therapeutics at UBC in the next month or 2. I'm just very quickly going to show you some of the results, and this is very preliminary. We kind of started looking at the data last week. So for our primary hypothesis, we had asked whether the WAF-CNS was able to distinguish a patient being conscious, here defined as looking at the 30 seconds before loss of count, from a patient who's unconscious, here defined as the patient looking at the first 30 seconds after losing the eyelash reflex. And as you can see, my pointy thingy, there's a nice discrimination between patients who are deemed conscious and patients who are not. And this p-value is not a p-value in terms of statistics. This is the probability of being able to distinguish the two distributions. So in 98.5%, we'll be able to discriminate between these two. And this is not taking any inter-patient comparisons into account at this moment. So it might well be that the patient who's up here may go further down and vice versa. Very briefly, to just show you how well you did. So the three main levels we were concerned with was a 1.2 MAC, as 1.6 MAC, and a 0.8 MAC, and they don't overlap. So when you read SAT, please do 1.6, you did 1.6, and such. And for the washing out the desflurane at the end of the procedure, it's a little bit more overlapping, but that makes sense because the steps were much shorter. And it might have taken longer for the desflurane to wash out of the patient. Just to show you a beautiful model case, what I'm showing on the bottom here is the end-tidal desflurane concentration in this red squiggly line, and the left and right WAF index on top here, so you can nicely see that when the concentration goes down, the WAF goes up, and if the WAF goes down, you see an associated increase in the vapor. If you just look at what values did you measure for each of these targets, just again focusing on the bottom ones, there's a lot of overlap, and this really highlights how variable it is and how much different patients behave. So a same patient may demonstrate very different levels of unconsciousness for a given amount of anesthetic vapor. All right. If you want, we can do one question now, and otherwise we would like to take all the questions at the end. All right, I'll hand over to Sonia.
Okay, good morning, I'm Sonia. Okay, I just feel like I'm not quite tall enough to. So I'm just going to be talking a little bit about our closed loop study. This is kind of our flagship reason we came and what kept us here the whole time. We called it I-Control-RP, so the R and P stand for remifentanil and propofol. And you can see a picture of it there, worked in beside the anesthetic monitor. So what makes it closed loop is we have our patient whose brain is feeding back into the neurosense monitor there. The neurosense monitor talks to a computer up behind the user interface, which then controls the pumps delivering propofol and remifentanil, which feed back into the patient, affecting the patient's brain, feeding back, and making a loop. So we're not the first, and we're not the only people to have come up with this crazy idea. There's a few groups around the world who are working on it right now, but we are the only people using our specific algorithm in Vancouver, and we're the only people using the specific neurowave monitor in our system. So this is very cutting edge, and we're pretty lucky to be a part of it. So the reason we were doing this study at Royal Columbia, and this was really kind of a preliminary study to get an idea of how things were going to work in a clinical setting. So first of all, we were just looking at clinical feasibility of using the system. And then kind of from an engineering perspective, we were gathering data to optimize control functions. And then finally, we were just collecting as much data as we possibly could from a clinical setting so that we could explore possible correlations and associations to generate hypotheses for larger trials. So the study was broken up into two phases. In phase 1, we had just propofol in closed loop, and remifentanil was in target-controlled infusion. And that gave us the data to then introduce the remifentanil controller in phase 2, so then both drugs were in closed loop for phase 2. And we hypothesized that by adding remifentanil in closed loop as well, so controlling not just depth of hypnosis, but also pain by closed loop control, we would stabilize the anesthetic further. And then another hypothesis that we generated partway through phase 1 was we were noticing some burst suppression pattern in the EEG, which is kind of a signature of very deep anesthetic and does funny things to our controller. And so we thought that by increasing the remifentanil in the presence of burst suppression, we would bring the propofol down and thereby get out of burst suppression and get a more stable anesthetic. So this just gives you a very general overview of the scope of our study. So from phase 1 in 2013, finishing phase 2 in 2015, we doubled the amount of procedure types we were going for, increased more surgeons, and got a lot more anesthetists on board. We had, I think, 15 in total that gave it a try, so some people had more than others, but you all can see your scores down there of how many you did. So just looking at a few results from this, we are mostly comparing phase 1 and phase 2 at this point. So they're very well balanced in terms of gender, age, and BMI. In phase 2, we had a few more ASA3 patients and a few longer procedures, probably because we got a little bit braver. And then looking at some of the procedure characteristics, the time to induction was about the same in phase 1 and phase 2, and a lot of you thought that that was a little bit slow. We did manage to shift the ratio of propofol and remifentanil by introducing Remi in closed loop. So you can see during maintenance, the mean propofol dose goes down a little bit, the mean remifentanil dose goes up a little bit. So overall, just the balance between those two is shifted. And as a result, the percentage time that the wave was plus or minus 10 of its target was improved from about 85% to 88%, going from phase 1 to phase 2. So that was a significant change. However, the percent time with a burst suppression ratio, so that was that pattern that I was talking about that was a little bit funky with the controller, that was not affected by this shift. So either the shift wasn't big enough or maybe it's not being detected accurately. That's something we need to keep looking into. So looking at induction phase specifically in phase 1 and phase 2, these crazy plots are every single case laid on top of each other. And then to clarify things, you can see the 90th and 10th percentiles with the median in the middle. So in both phase 1 and phase 2, like I said, the time to induction was about the same, and we see the same pattern where we get a bit of an overshoot and then we stabilize to 50 and keep it there. One thing we'll see, so the blood pressure is the second line here. It tends to drop in line with induction, and that's normal. In phase 1, it tends to come up a little bit after induction, whereas in phase 2, it seemed to not bounce back quite as quickly, probably because we were giving a bit more Remi in phase 2. And then one thing we found also is that 36 out of 76 patients in phase 2 required either ephedrine or phenylephrine after induction, so before the procedure had even started. So it looks like we were actually causing quite a bit of hypotension after induction. Problem is we don't really know how that compares to general standard practice, but there was more in phase 2 than phase 1. And then quickly looking at a little bit of the maintenance phase. So again, all the patients laid on top of each other. You can see we have a really nice distribution between 40 and 60, which is considered an appropriate anesthetic. One thing I wanted to point out again with the blood pressure is these are all normalized to the start of surgery. So time 0 is the moment the skin is cut. And in phase 1, you see a generalized increase in blood pressure, which would suggest some sort of body response to stimulation. In phase 2, that's pretty much washed out. So that would kind of suggest that the remifentanil in closed loop was actually doing a better job suppressing some of the sympathetic activation after an incision, which would speak well to its hemodynamic stability. However, we still did require more ephedrine and phenylephrine in phase 2 than phase 1. So with that increased Remi, we block blood pressure going up, but we keep driving it down. Yeah. So that was totally left up to the anesthetist. We said you could intervene hemodynamically however you like. You can kind of take all the variables into account. The controller is adjusting the propofol and remifentanil as it does, and then you can do whatever you need to for blood pressure. So because we didn't have a control group in this study, I thought it was important to ask all of you who had participated how this compared to your regular practice. Hopefully we've got a generator. So anyways, because we couldn't compare, we had you guys compare to what you thought was normal, basically. And there were 15 of you who participated. We didn't include Richard in this analysis. So 11 of you responded in the end, so it was a pretty good sample of everyone who did participate. And I think overall this does look pretty promising, so people agree that hemodynamic stability was either better or about the same as what they expect. Induction time was definitely slower, and that's something that we are going to work on for future models. Emergence time, we're not really sure yet, and we didn't follow the patient much into recovery, so we're going to need a lot more variables to see whether or not there's an effect on emergence. Whether or not the neurosense was providing an accurate measure, most people thought yes or maybe, and I was really encouraged to see that at least half would say that they would use it again, even if it wasn't a part of research. So if it was just a commercially available monitor in the OR, they might consider using it as part of their anesthetic. In terms of complications, I just asked if anyone had maybe thought that they had a complication that was specifically related to the eye control system. One anesthetist said that they had one patient with postoperative agitation and delirium. It's hard to say any causal relation with that. Overall, those are pretty poorly understood. 3 anesthetists did mention that there were some responses to stimulation, and that is something we saw. So, and that I'll talk about that in a little bit. And 3 anesthetists also commented on the hypotension after induction, which we've also pointed out is something that needs to be addressed. I also just, from a very qualitative point of view, wanted to know what people liked and didn't like. So some of the themes were that people liked the concept. It was intuitive, easy to use. It's nice to have a bit of extra information on your anesthetic. And it's kind of nice to be able to focus on other things without having to make small adjustments in drug dosing. And some of the things that people didn't like was that it's a bit intimidating to have a machine in the room making drug dose decisions for you. Our module itself is taller than me, so it's large, bulky, and a bit cumbersome. Some people didn't like using remifentanil or thought that our study protocol specifically didn't exactly line up with their anesthetic practice. A few people thought maybe the neurosense wasn't good enough as a sole feedback agent for closed loop control, which is something we're also thinking of, is adding other parameters, bit of a more vanilla setup. And then this comment about the lag time between change and response. That's something that is kind of tricky to use when the controller can only respond to a change. It can't predict a change. And I think that's just something that we could have done a better job explaining as a research team too, is that as the human in the room, you're still able to observe and make a change prior to something happening. So before they make an incision, or if something, some different kind of stimulation is coming up, you can predict that and make changes within the controller beforehand. I also was just curious if anyone felt that they learned anything. Some people said no, but other people said yes, and that was good. Overall, the general theme was that people were surprised by how much less anesthetic the machine gave rather than what they would have given. And that really speaks to the potential for closed loop control in the future, giving an individualized dose of anesthetic. So we conclude at this point that it's clinically feasible. It still needs work. We did show that adding remifentanil in closed loop improved stability, but it also increased hypotension and did not resolve burst suppression. So back to the drawing board in that sense. Like I said before, the controller can't predict stimulation, and that's maybe not a limitation, but a potential for workflow integration between anesthetists and using the device. What we're going back to do now is work on the induction profile to get it a little bit faster and less of an overshoot, less hypotension. Hopefully trying to specify our burst suppression detection a little bit better, making the design smaller so that it fits better in the OR. Like I said, workflow integration, and then a couple of future studies that you can look forward to in the next year that we have in the mix right now, one using closed loop and ketamine, and another one using closed loop and comparing it to the standard of care. So that's kind of the big ultimate study that we're working towards. And that's it. Should we just wait to the end for questions?
Good morning, everyone. My name is Nassim, for those of you who forget me for a while. So I've been here working on warming study for almost a year and 2 or 3 months, maybe. So I'm here to present, and I'm so excited to give you a little bit more information on this study. So it was, this is a randomized prospective study to determine the effects of pre-warming on OR patient temperatures and to look at pre-operative surgical outcomes. So as we all know, hypothermia, meaning that core body temperature less than 36, is a significant cause of morbidity and mortality intra and post-operatively. And thermoregulation is significantly impaired during general anesthesia, and because the core temperature reduced within the first hour of induction due to peripheral redistribution of body heat, and we would like to avoid that. In previous research, it has shown that intraoperative warming, it's effective to somehow improve that and prevent hypothermia, but in this study we would like to see the impact of pre-warming as a component in addition to intraoperative forced air warming on adverse preoperative outcomes. And we would like to see the effects of preoperative forced air warming on incidence, proportion, and depth of hypothermia, as well as the secondary outcomes looking at incidence of surgical site infections, transfusion requirements, and also post-operative analgesic requirements. So overall, we recruited 200 patients. We had a rather broad inclusion criteria. We included all of those patients that they came in with elective surgery for more than an hour, ASA 1 to 3, and if they consented to the study. Also, we didn't include any patients with emergency kind of operation with the length of the surgery more than 1 hour, less than an hour, and more than 6 hours. And also if they had any kind of hypothermic or hyperthermic pre-existing condition, we didn't approach them. After getting consent from 200 patients, we randomly assigned them into intervention or control group. In the intervention group, we asked them to try our purple fancy gown from 3M, and in control group, we just gave them the usual warm flannel blanket here at RCH as a like usual clinical practice. In both groups, they received intraoperative forced air warming with overbody warming, and both groups, we collected the spot-on temperature monitoring, and also we collect all the vital signs with our software in the while they were under the operation. So the stratification was based on the procedure length, less than 2 hours and a half and more than 2 hours and a half. So basically we had like 2 groups of people, and then finally we tried to look at the final analysis, final data that we had from these 200 patients, which Matthias is going to give you more details around that. I can just say that we screened 490 people at the beginning, and out of those 200 patients finally consented to the study. Thank you.
All right, very quickly, because I think it is important for our primary outcome, I wanted to explain or mention how we looked at the, or how we quantified hypothermia. And the main outcome we looked at was an area under the curve. So imagine the 36-degree threshold being here, and the patient's temperature being the gray curve. And so I would just look at how big this red area was as the primary outcome. So I'd integrate for every time increment how far we were from the 36 Celsius. In terms of outcomes that were followed from primary chart review and then some follow-up, as I said, intraoperative hypothermia was what the study was powered to look at and what our primary outcome was. And the secondary outcomes included the surgical site infections, 30-day or 90-day follow-up with implants according to the NISQ criteria. And then we looked at things like blood transfusions, estimated blood loss, patient comfort, and I won't touch on the patient comfort one. So to start with, we did a nice job in randomizing patients. just showing you some demographic information. The only one where there's a difference is that there were more urology procedures in the standard of care group than there were in the pre-warming group. All the other ones have no significant or clinically meaningful differences. There was also a small difference in the baseline temperature, which was potentially due to the fact that the patients in the pre-warmed group already had the gown on when we acquired their first temperature. But the difference is 0.1 degrees, which may not be very big. Because we use spot-on, in addition to the esophageal and the nasal temperature probes, I thought we very quickly needed to establish that this was a valid measurement for analysis. So I'm showing Blount-Altman plots as a heat map. So if there's more data points in a certain bin, the darker one of these squares gets, and the fewer there are, the lighter the squares get. And I just look at how much error is there between the two temperature measurements for a given temperature. And the bias was almost zero, and the two standard deviations in terms of error were plus minus 0.4 degrees, which is a very good agreement between the two measures. And this is true both for the nasal temperature as well as the oral temperature. It's a bit tighter for the oral temperature. So looking at our primary outcome, which was the intraoperative hypothermia, on the top is the patients that were pre-warmed. On the bottom are the patients who were in the not pre-warmed group. I just looked at the incidence at any given time of a patient having a temperature under 36 in red, under 35.5 in green, and in 35 in blue. And so you can clearly see that patients who were not pre-warmed spent more time being hypothermic. And you can also appreciate that there's no difference, or there's a big difference. There's no patients here that are under 35 degrees Celsius, and there's a whole bunch of them that are here. And then similarly, there's a difference in 35.5. So to summarize the outcomes, as I said, our primary outcome that the study was powered to was to look at the area under the curve. This was significantly different. The difference was about 2 degrees per minute, which is a bit of a funny unit, but if you want something that's more tangible, the percent of the case that a median patient spent hypothermic was 0 in the pre-warmed group and was 13% of the entire case length in the non-warmed group. They came and arrived in the pre-operative care unit, slightly warmer, again significantly. The study was not powered to look at these secondary outcomes, which is likely the reason that we did not show a difference in surgical site infections, blood transfusions, mainly because very few patients received blood transfusions. So what I'm showing here is the median and the interquartile range. There was no significant change in reduction of postoperative opioid consumption in morphine equivalents. There was one confounding thing that might need to be taken into consideration, which is that the patients in the pre-warmed group got slightly more warm fluid, and then in turn obviously got slightly less cold fluid. And it's a confounder we need to take into consideration when we do our data analysis. But we confirmed our primary hypothesis, which was when we pre-warmed patients, they had less intraoperative hypothermia, and we were not powered and clearly did not demonstrate that we improved any of these secondary outcomes. But if ever we wanted to do such a study now, we would know that we need about 3,000 patients. All right, that's the point for questions. So thanks so much for all your help with this, and I guess you can all come up and then take some questions.
I'm going to turn the microphones on to you guys as well now. So any thoughts, comments, questions on those three very, very quick and brief presentations of those three studies?
Let me start out by asking, because the NeuroSense monitor is the EEG monitor that's been used. I use in the OR we have a bunch of VIS monitors, and in most ORs we have a entropy monitor. And it's my casual observation, the entropy monitor correlates with almost nothing. Even though a while ago I said it was a better monitor than the VIS monitor. So the developers of the NeuroSense monitor are not here, but can one of you tell us why we believe the NeuroSense monitor is a better monitor than those other two? They're all looking at the EEG.
They are, and one of our colleagues who's not with us here today, Chris Peterson, is looking at sort of direct comparisons between the NeuroSense, the BIS, and the entropy. And although yes, we often explain the NeuroSense to people and say it's just like the BIS, but actually it obviously isn't. They don't work these things out in the same way. The thing that the NeuroSense is really being designed, or the focus of its design, is really to be able to drive the closed-loop control anesthesia system. You can probably, or Francesca can probably explain a little bit more why that's, what the features of that design are that make it appropriate for closed-loop, and why therefore we think it's better.
Primarily,
Code white emergency trauma 3. Code white emergency trauma 3. Code white emergency trauma 3.
That's Chris answering the question.
yes. So there's a few features. I think the only ones I would like to touch on is it is probably a little bit faster to respond to changes than BIS does. It also has or we hope it has a linear response, so the change between 50 and 55 is the same change between 80 and 85, which is not true for BIS and entropy, which is a feature that we need for this closed-loop control system. So it's probably a bit more responsive. It has some characteristics that allow us to do better control with it. And we also hope that the algorithm is better, but we have not done any definite studies on this. But as Nick elaborated, we're doing this nice study where we now replay EEG in all three monitors, so we can compare them against the same input signal. And they are very clearly different. And one of the things that, if you've done used BIS before, that you may realize very quickly is that it has states. You see this at emergence, that the patient may go from a very high number, may switch between very high numbers and anesthetized numbers, just because the system switches state, which may not be reflective of the patient's actual state.
And we did meet with the NeuroWave developers just a week or so ago, and they're very interested, obviously, in the data that we've gathered here, in terms of feeding into their understanding of what their algorithm should do, and perhaps especially as Sonia alluded to, this idea of looking at the detecting suppression and bursts, the burst suppression pattern that we see during very deep anesthesia. And then, so it's very much not necessarily something that is obviously wholly understood. And I think the data that we've gathered here as part of both the studies, the closed loop and the NeuroSense study at Eagle Ridge, will help to understand that a little bit better.
I'm really impressed with how many patients you were able to consent. So how difficult was that? Or how easy?
In warming study?
In any of the studies? I can't remember the total sample size, but...
Yeah, so there was 200 in the warming study, there was 150 in the closed loop and 76 in the NeuroSense.
So do you recall how many patients declined to participate at all?
We do have that information. I don't have it off the top of my head. I think people found the so probably best to answer for each of them really. To some extent, the NeuroSense study was really just a question of applying an additional monitor and then running some randomized changes that were all understood to be within a clinical range and could be accepted or rejected by an anesthetist. So I think many people who came felt that study was just some extra monitoring. But actually, in that case, wasn't monitoring that the anesthetist was getting any benefit from. So to some extent, we were asking those patients to really just be guinea pigs in a way. With the closed loop study, I think people find the idea actually quite appealing, that we're trying to drive towards finding an anesthetic that is personally matched to their own, to themselves. So I think people found that conceptually quite appealing idea. The warming study, again, it's a question really of whether they were prepared to have an envelope open to say whether they were going to sit in a purple gown that we were going to shove some air into and sit in surgical daycare with that on. And maybe that's why we had a slightly higher temperature, because of the slight embarrassment factor of patients wearing the purple gowns. But I think we didn't find it too difficult. We're a very supportive environment in the surgical daycare here. It was a little bit, it's a bit smaller and busier somehow, it seems, at Eagle Ridge, although it had very little experience of it. But here, it seems quite a calm, nice environment. We did go and recruit quite a lot of patients in the pre-anesthetic clinic as well, especially for the walking study.
How are the control numbers arrived at for the neurosense? In other words, how do you decide what target you want to?
So the target is set by the anesthetist, and we start, the proposed target that we start with is 50.
In the neurosense study?
In the neurosense study.
In the neurosense, yeah.
The neurosense study had the anesthetist blinded to the neurosense monitor. This was the study where we randomized the entire destrain concentration.
Okay, so but your feedback loop has to decide what number to do. So how did you decide for the feedback loop? I mean, it doesn't matter what the anesthetist thought.
Okay.
How do you decide that 50 is the correct number, or 75, or 25, or how is that number arrived at?
Well, that's good. That's a good question. So the understood accepted range of anesthesia is 40 to 60. So we started with an initial set point of a wave index of 50 for all patients, but we allowed the anaesthetist to make assessments to decide whether that was too deep or too light. So they could put in fact, we only had it in increments of 5, so you could put it up to 55, or you could put it up to 60, you could put it down to 45 or down to 40. And people did, based on a number of factors that they decided the patient needed a deeper anesthetic or needed a lighter anesthetic.
So was there any consistency to that? Did it overall, when you look back, did most anesthesiologists leave it the same, or did most tend to adjust it up or down? I mean, maybe there's some message in that the settings are too...
This is a bit of speculation, but it seemed that changing the set point was primarily based on hemodynamics. So if the blood pressure was on the high side, they went with a lower set point, and vice versa.
And has this shown any advantages compared with blood pressure control feedback of anesthesia? Which has
may get there at some point.
Okay.
It is one of the things that we have thought of, and there's obviously David Green's work, who's quite extensively looked at blood pressure control, and now starts all his patients on a phenylin infusion even before he gives them the first amount of anesthetics. It is certainly something we're considering to take into consideration to either help the anesthetist make a decision of when to change the set point or partially automate this. I think it's give us another 2-3 years, and we're going to present something to you which may or may not have addressed this problem.
I think there might be two answers to your question. One is that to go back to the original question, the 40 to 60, why is 40 to 60 asleep? Well, it's because the company, BIS set that model aspect, and then the entropy model followed it, and presumably the neurosense investigators decided that using the same scale was appropriate. So the range of 40 to 60 is felt to be good general anesthesia, and so you got to choose an initial set point. So the initial set point was chosen to be the middle of that range. And then how you managed it beyond that. And I tried very much when I did the cases to let the machine do everything, to not interfere and make my own mind up. And so if the blood pressure was going up and the wave was within acceptable ranges, I would try to treat the blood pressure, and assuming that the blood pressure was a response to pain, but not to requiring more sleep. So going back to the old days of anesthesia being lack of consciousness, lack of response to pain, and lack of movement, I would treat the pain separately by increasing the remifentanil infusion rate or whatever. And then very occasionally going and treating the blood pressure itself very specifically. I tried not to give ephedrine. I told the residents they weren't allowed to give any drug without asking Sonia. And then Sonia's weak because she let them give drugs.
but I think, it is an important question, actually, and I think sometimes anaesthetists would change the set point based on their clinical observation of the patient or other monitoring. But I think also to some extent there was a feeling sometimes that you could actually get a better control of the depth of the wave index itself by just adjusting, because obviously not all patients, 50 is not the ideal anesthetic set point for all patients. So sometimes we actually found that the control system worked better if there are some patients, we maybe dropped it to 45 or increased it to 55. And in fact, in the latest version of the controller that we're now using at Children's Hospital again, we've actually allowed to finer gradations of set point changes, so we can now change it to 52.5, to 55, to 57.5, and so on, to allow that slightly fine-tuning adjustment of this is the best anesthetic set point for this particular patient.
And with the entropy, I've had some patients who are clearly asleep. I mean, they're not responding, they're not doing anything, their blood pressure's fine, their heart rate's fine, and the entropy number says it's 88.
Yeah.
You know, I say, what's going on? So Michael Avendon, when he gave a talk, you know, he's one of the real EEG gurus from Washington State. He's another South African friend of Ansermino's. Ansermino has South African friends all over the world. He said you have to look at the EEG. You have to look at the raw EEG, and I think that's obviously true. And sometimes I would have a wave not a wave, entropy index of 40, and say, oh, that's okay. And then you got burst suppression, like it's 50% burst suppression. Well, burst suppression is a sign of very deep anesthesia, we believe. So you can't trust those numbers, but look at the EEG and see burst suppression and say, well, clearly I think clearly, as much as I know about burst suppression, there's more anesthesia there than I need. So, but it's a new world looking at the EEG for sure.
So outside of Richard, do people use entropy or BIS? Both. Routinely, or?
I use entropy because Richard made me use it. Yeah. I think the only thing entropy has going for it is it's a nicer electrode setup.
Right.
It goes to the correct side of the patient. It handles well. But I've had patients that I'm extubating and their entropy is still 60, and I leave it on. Yeah. And as we're leaving the room, I'm disconnecting it. They're talking to me, and it's 70. That doesn't make sense to me. The lag shouldn't be that long.
I think the biggest failure with these things is the lack of prediction. So, for example, even on your little graphics there, it goes from 100 down to whatever and along, and then you wake them up and it just goes up like that. And what I'm looking at is something that will gradually be moving along. I know that wasn't the purpose of the study, but usually when you're using entropy or BIS, to tell me, oh, the patient's getting light, instead of suddenly the thing goes like this and the patient's moving. Oh, I can tell the patient's moving myself. I don't really need that to tell me what I can see. I'm concerned in terms of the positive comments there, and Essa says, oh, it frees me up to do something else. Well, what else are you supposed to be doing except looking after the patient? I mean, coffee, crosswords, I don't know, but
we got the EMR,
supposedly the patient is number one. So.
Calligraphy.
Another study that's being done, I think, is Grisdell doing it, and when I talked to the administration group here, Steve Reynolds was quite keen on a sedation study, ICU sedation. So there you're targeting, what, 70 or something like that, rather than 40 to 60. And I think that will be very interesting to know whether it really is linear at that level. So, is that an active thing going on, one with the VGH group?
So we've tried to acquire CHR funding to do a study looking at sedation automation in the intensive care unit. And we were unsuccessful in the last round, and we're going to resubmit for September.
So the funding issue.
And maybe the one comment Sonia could make is the patient who bled quite a bit, and the impact of closed loop control on that.
All right, yeah. So just in terms of other things you might be doing instead of watching your anesthetic dosing, I'm writing a case report on one particular case that we had that required blood transfusion, and it was completely unexpected. It was a big bleed that wasn't anticipated. So there was Richard phoning to order blood. There was the resident giving big fluid boluses, and something like a big bleed really changes the sensitivity to anesthetics because you have less cerebral perfusion when your blood pressure and cardiac output goes down. So in something where it's changing so much, no one in the room had time to change the anesthetic, but the controller was making the adjustments based on what the patient needed at that time so that they could focus on emergency situations. That's one example. So yeah, in general, the argument is not that it's going to make every single case better, and you might have more time to do your crosswords most of the time. But just in a situation where something unexpected happens that requires decision-making and high-level thought, you can dedicate all of your attention to that instead of having to worry about drug adjustments as well.
A comment and a question. The comment is that having worked with the team for about a year, the tax study, it's a tremendous group of people. For those of you who haven't had a chance to interact with them, and real asset to our hospital. They've been here last couple of years at the Richards work. So hope we can keep some of them for other studies down the road. The question I have is, being the single lead EEG monitor, either this one or the BIS or the entropy, and the emerging evidence that inhaled anesthetics and others work through impairing the connectivity between different parts of the brain, different hemispheres, is there any move to look at multi-lead EEGs in the next iteration of monitors as a better, more reflective tool of guiding depth of anesthesia?
So I'm not going to try and answer that, but I'm going to again put it on Sonia to try and answer that question.
I could say some studies do that. Generally, not ones looking to develop a clinical commercial monitor, but studies looking at how do anesthetics put people to sleep. And so they do look at full cap EEG and get an understanding of, yeah, the lack of connectivity from the front to the back of your brain. But in terms of just feasibility, putting a full cap on someone before they go to sleep is just, people aren't going to use it. It's super annoying. You've got way more channels to make sure your connectivity is good. And mostly what you're interested in is consciousness and awareness, memory formation, and things like that is mostly going to be happening up front. So it's kind of a surrogate marker of what's happening in the whole brain.
Just wondering if you guys have any experience with the Massimo subline.
I have none.
We've seen it presented at lots of conferences, and as Richard alluded to, Mark Adevan is working with them closely. We've never had one, so we've not had the opportunity to play with one. It is one of those things, if we can lay our hands on it, we would like to include it in this replay study where we take the same EEG and stick it to all the monitors and see how each one performs compared to the other ones, but we currently don't have one.
Questions? How did they get so many consents? Because it's really, consenting is, as you know, it's an art. And these guys, well, Nick's accent helped a lot getting and Sonia's smile, obviously, it's they're just very successful at getting consents. There's really only very few people who, I'm not sure the statistics, but the majority consented. And in fact, the one that I would guess was the least successful was the warming, which is the silliest study to refuse in the world, because it's just warm blankets. What the heck can you refuse about that? But the odd person doesn't want any interventions done.
Nassim, do you remember the numbers? How many were approached?
Yeah, we approached 490 people, and we got 238 consents, and we had like 220 withdrawals, almost. And we included 200 completed subjects. And let me just thank Erin, because she was very helpful, and actually she was the lead in warming, and she was the one who is taking care of all the follow-ups and also helping me with the recruiting. The rest of the team, Alex, she's not here, she's doing her med school in Australia, and also Aaron, the resident, he's not here now, but and also the rest of the team, Sonia, Nick, and Matthias, they were
keen med students help with consenting as well.
So that was not just me, but we tried really hard to keep our timeline to get all of those
So
200.
the purple socks representing Alex was, we never gave out those to the patients, but they were great gifts to the nurses.
And I think Anna, who made sure we got the funding sent off appropriately, which was pretty useful. And Megan, who kept everything in line, as I understand. And Klaska, who looked at the EEG from every single patient, I think. Is that right? Pretty well. Thank you very much, then. With that, we'll accept your donations. I appreciate everybody coming.